Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchett. Today's episode is part 12 of an ongoing series titled COVID-19 Answering the Questions. This series features brief updates on the latest incidents and clinical data related to COVID-19 diagnosis, prevention, and management, each followed by an in-depth question and answer session designed to address infectious disease specialists' most pressing COVID-19 questions. During this episode, Professor David Heymann from the London School of Hygiene and Tropical Medicine in London, England, will provide a brief update on strategies for moving forward and living safely within the continued COVID-19 pandemic. For more information about Professor Heymann and for a link to additional online education from CCO's COVID-19 Comprehensive Resource Center, please visit the show notes for this episode. Now let's get started and hear a brief COVID-19 update and answers to clinician questions by Professor Heymann.
Thanks very much, Jen. And today I'm just going to be talking a little bit about what we understand on the epidemiology of SARS coronavirus 2 and how we can really learn to live with this pandemic moving forward. And as you'll know, the confirmed number of cases is at 43 million, the deaths over 1 million, and recovered 29 million. And you can see here in the three columns those countries that are reporting the highest number in each of these areas. What I think is very important to understand from this slide is that confirmed cases are not necessarily people who have clinical illness. What they are is people who are infected. And what countries report to the World Health Organization is the number of persons with infection that they've identified using their own testing strategy, which varies from country to country. So really, confirmed cases is not a good way to compare one country to another. Much better is to compare the deaths, which are probably more reliably reported and more easily discerned. So moving on then to the next, I'd just like to talk a little bit about the future of the COVID-19 pandemic. And the big question today is, will this become endemic? And there's a likely scenario that SARS coronavirus 2 will become endemic, as did 4 other endemic human coronaviruses, though the long-term destiny of this virus is really not known. But as you know, there are 4 other endemic human coronaviruses that cause the common cold, especially in the winter months in the Northern Hemisphere. Some definitions that are useful in dealing with COVID, because COVID does occur in outbreaks, greater than anticipated increase in the number of cases or a single case in a new area. Unlike influenza, which spreads rapidly into communities once it's introduced into a country or a region, COVID causes discrete outbreaks that can be contained. Epidemic affects a larger number of people within a community, population, or region, and a pandemic is an epidemic that is spread over multiple countries or multiple continents, and many times a pandemic will become endemic, such as happened with HIV when it spread around the world. So endemic means perpetually existing within a geographic location. So anyway, living with COVID-19 pandemic using the tools we have is very important. Countries that have contained COVID-19 outbreaks and kept community spread to low manageable levels have done so by taking a precise epidemiological-based approach that includes active case finding, forward and backward contact tracing, and strategic testing linked to surveillance and diagnosis with rapid return of results. It's just not on to have testing that gives you a result 24 hours later if you're trying to contain an outbreak. So in order to live with the current pandemic, there are some assumptions that are important. One of those is that understanding trust and participation by all population groups is extremely important. Populations really can determine whether or not this pandemic will continue if they can learn how to do their own risk assessment and prevent others from getting infected while preventing themselves from infection as well. SARS-CoV-2 transmission can be decreased using basic epidemiological and public health interventions that have been successful in many other outbreaks in the past. And all public health departments and groups know how to do these. And at the same time, acknowledgement that potential COVID-19 vaccines and therapeutics will only be part of the solution and will be most effective in conjunction with long-term overall public health strategies. So by waiting for a vaccine and saying the problem will be over is really a false security. This disease likely will be with us, and a vaccine will be one of many tools that can be used to deal with the pandemic. Many characteristics of the SARS coronavirus 2, however, are not yet fully understood. The immune response and the duration of protection against infection, if it does occur, is not really known. We do know now that there have been at least 25 people who have had initial infection, been diagnosed with infection because they had signs and symptoms, and now they've developed a reinfection. This is talking about people who had clinical illness. We don't know what's happening to people who have not had clinical illness, who may have been infected. Are they now getting reinfected as well? Not possible to say at present. Also, there's missing information about the implications of identified reinfections following previous clinical illness. And the full spectrum of disease and the long-term sequelae are not yet really understood. So the advisory group to the emergencies program at WHO has recommended that with current knowledge, even in the absence of COVID-19 vaccines or treatments and comprehensive knowledge of the immune response to SARS coronavirus 2, countries can navigate pathways to reduce transmission, decrease severe illness and mortality, and less economic disruption in both the short and the longer term. So what can we do? Well, there's a checklist of things that we can do. We can rapidly detect people with infection, outbreaks, and sites of increased transmission by strengthening surveillance for influenza-like illness and acute respiratory infections. And we can establish systems for identification in health and other sectors and link those with rapid turnaround testing. We can isolate and manage people infected with SARS coronavirus 2. Everyone can do this in health facilities or self-isolation at home. We can all have our public health departments investigate outbreaks, find not only where people have been, find out and close down sources of infection by tracing back to the source of outbreaks. At the same time, we can decrease community transmission by contact tracing forward and isolating those people who are contacts. And finally, strengthen control measures, fully engage populations in self-protection and measures to protect others. All of these are possible to do in any country. They require no equipment except for testing, which is now becoming available. At the same time, there are more issues. There's ensuring that testing is strategic. Many countries like to say we've done 2 million tests in the past week. That says nothing. What's needed to be done is strategic testing, knowing what's most cost-effective, what's sensitive enough and specific enough, using a choice of nucleic acid, antigen, or antibody tests that are linked to surveillance, contact tracing, diagnosis, and management. Also, there's a need to protect the health and social care system by monitoring bed availability, monitoring mortality, and making sure that infection prevention and control is what it should be so people are not getting infected in these situations. We can continue general mitigation, postpone large mass gatherings, very important to make sure that people aren't too close together. Involving business and private sectors, they have many innovations that they're already working on that can provide a safe workplace, and governments need to be depending on them to help decrease instead of sometimes just ignoring what they're trying to do. Applying short-term preventive and mitigation measures when you do identify sources of transmission, but then opening those up again after you've closed them. And finally, conduct, fund, and support research, and support especially research and equitable access to COVID tools such as vaccines, diagnostics, and therapeutics through the ACT Accelerator, which is a $9 billion venture which is being run by the European Union and to which many countries adhere. Finally, there have been countries that feel that they've eliminated the disease entirely. This is very important to know because when they've eliminated the disease, it is no longer transmitting in their countries. So in New Zealand, They believe that transmission was interrupted for 103 days after the first case on June 8th, 2020. And since then, they've been seeing cases that have come in from importation, but they've had a total only of 25 deaths, and current cases are 0 in the hospital. This is a very wonderful accomplishment. The question is, how will they now safely open up to make sure that their tourism industry, on which they depend, can again become healthy and contribute to the economy? A very difficult question for them to answer, and they'll be trying various methods of screening of air passengers and self-isolation or forced isolation moving forward. There's evidence that there are some ways that we can decrease transmission and protect ourselves. One of those is by maintaining an adequate distance. And at the bottom on this slide, you can see distance in meters at 1, 2, and 3 meters. And on the left, you can see the absolute risk. And if the absolute risk is greater, of course, it spreads easier at each of these distances. But if you look at the bottom lines, you'll see that at 1 meter, many of those risks of transmission are at a low level. And that's why the World Health Organization recommends 1 meter distance between people. In the US, they recommend 6 feet, which is about 1.5 meters or 1 2/3, and other countries recommend other distances. But the general rule is that 1 meter separation is the minimum that you should permit in order to prevent yourself from getting infected. Mask use has been very controversial, especially in countries like the United States, but there have been some studies, some systematic reviews, and some actual studies. And on the left, you can see that there was a systematic review and meta-analysis of 172 studies on the spread of SARS coronavirus 2, SARS, and MERS. And these showed that facial masks were associated with an 85% reduction of infection. It's, of course, a greater odds ratio for those that have an N95, but all masks are effective in decreasing the transmission and infection. At the same time, there's an association for stronger N95 or respiratory versus disposable or 12-16 layer masks, and eye protection with N95 decreased infection of the non-infected. So the systematic review has shown that clearly masks are associated with a reduction of infection of individuals. The study of human coronavirus in droplets shows that masks can actually capture droplets. And in the first study in Hong Kong, virus in droplets were found in droplets in 3 of 10 samples collected without face masks, as opposed to 0 of 11 samples when they were collected in front of a face mask. And the same is true with aerosols in 4 of 10 samples collected without face mask versus 0 of 11 samples with a face mask. So it's clear that there is individual evidence-based prevention measures that people need to understand in order to protect themselves from getting infected and to protect others. And that includes maintaining that physical distance, wearing a mask, especially if physical distancing is not possible, and if you're caring for patients or for people who might be susceptible to infection. Keep rooms well ventilated, avoid crowds, wash hands, and cough into a vent, elbow, or tissue. So at the right, you'll see maintain at least 1 meter distance between yourself and others, maintain an even greater distance indoors, and at the same time, make wearing masks a normal part of being around other people.
Thank you, Professor Heymann. The first participant asks if there have been any additional data to inform why it appears that men get more sick than women from COVID-19.
You know, there is no information on that, and there are lots of questions about why this might be occurring. There are many hypotheses. One is that sometimes or in the past, men have smoked more than women and their lungs are more susceptible to infection or serious illness. That's one hypothesis. Others are in general that men may have more comorbidities than women. But really, nothing has really been shown as to why this is occurring. And all that we can do is say that there has been speculation that it might have to do with comorbidities or some other factor that men, for some reason, have a greater risk of infection or serious illness rather than women.
Okay, great. The next question is, are there a sort of similar association type question? Are there studies supporting the claim that an association exists between blood types and COVID-19 susceptibility or severity of disease?
Well, these studies are very early on, and what people are concluding today, the scientists are concluding today, although this is only very preliminary data, is that type O may be protected against infection for some reason or another. But that's all I can tell you. I'm not sure about any definitive outcomes because they haven't been published yet.
Right. Okay, great. Just interesting speculative information at this point. We've had a couple questions asking about N95 masks.
Yes.
Can they be reused, and if so, how?
You know, I think that depends on what the situation is in the country and what the hospitals are recommending. In general, a mask is not reused. However, there are some instances where it's better to try to clean a mask or to clean it, to sterilize it in some way, and then reuse it. And sterilization measures might include anything from UV light to other procedures. But there's no general recommendation on this. This depends on the situation of masks, the costs of the masks, and whether the hospitals can afford or the health systems can afford to purchase them. So there are, it's best to look at your local guidance rather than to try to get general guidance on that.
Right. Okay, great. So Abdul asks, there appears to be this new surge of COVID-19 happening, and wondering if you have any thoughts on what's contributing to this.
Yeah, thanks, Abdul. That's a good question, and I think some of the reasons that people believe are as follows. When the lockdown occurred in many countries or many states in the US back in February and March, countries really had no exit strategies. And so then when they decided to stop these measures, they just stopped them across the board. And what happened was that people were pleased to be out of the lockdown situation. And especially the younger people congregated in nightclubs in areas where they could have a drink together or other things. And it's thought that they became infected. And now we're seeing the result of that increased transmission in those people. And then it's spreading elsewhere in communities and in families. That's one hypothesis. Another hypothesis is that as people move indoors, transmission is easier, especially if they're not wearing protective equipment or protective masks in households especially, and therefore transmission is increasing because people are more in the household and together. Up until recently, it was thought that it took quite a substantial amount of time, maybe minutes, in order for people to infect each other. But now it's becoming clear that it may even be less time, as has just come out from CDC in Atlanta.
Okay. Great. We've had a couple of questions. This is on transmission as well. One from Lillian and one from Rasha, really asking about what we know about how much children may be contributing to the spread of COVID-19, and particularly as schools have reopened in many places or are trying to.
Well, there's a lack of evidence right now, but countries that have been looking in households of children who have gone back to school are not finding that there's an increased level of infection in those households. So that's possibly an early sign that children are not taking infection home from schools. And in addition, some schools have been open and found only 2 or 3 children with infection during a period of months rather than a great number of children. So it's just not clear exactly what the school situation is, but I think most countries are now feeling that it's more important for children to socialize and to be back in a school setting than to be in a setting where some have computers and can do distance learning, others don't, or others don't have a parent who can help them. And so I think in general, countries are trying to move back towards getting children in school, but monitoring very closely to see if transmission is any way increased in their families.
Right. Okay, great. Amos has asked a question about if you have any thoughts or steps that you could propose that would be the best way to begin testing in the workplace.
Well, it's interesting in the workplace. The problem with testing is that it gives you a result today, and tomorrow you might go out and get reinfected, or you might tomorrow develop a positive test that wasn't positive the day before because you were still in an incubation period. And so industry is trying to figure out if there is a need for a testing strategy in industry, because remember, where they go to work is only part of their day, and then the rest of the day is at home. So if you test in your company and say every week we're testing and we'll let people back in and we'll make sure that our environment in the company doesn't transmit infection, what happens in the community when they go home? So that's the dilemma they're up against. But some countries are actually pooling specimens, 10 specimens, and testing those either for nucleic acid or for antigen. And others are testing with a rapid point of care antigen diagnostic test, and then repeating that every week. But there's really no clearly defined strategy that appears to be fail-safe at present. And so industry is struggling with trying to figure out and understanding that the best way is to prevent infection at the workplace by permitting physical distancing, by making sure that there's good ventilation, and by making sure that those with comorbidities have the possibility of remote working.
Okay, so protecting vulnerable populations and then having mitigation in place. At least in the U.S., there are some universities that have started doing basically it's fecal testing, but using sort of sewage from dormitories to identify potential outbreaks. Any thoughts on the efficacy of that?
Yes, well, environmental surveillance is what that's called, and it's been very effective in other programs. For example, in the polio eradication program, it's been very effective in finding those enteroviruses, those polio viruses that are enteric viruses, in the sewage systems. So for polio, it's been very effective because the virus is very much in the feces, a live virus is in the feces. In COVID-19 and SARS coronavirus 2, PCR fragments are identified in fecal matter, and there have been occasional isolations of virus from fecal matter. So yes, environmental surveillance may be able through a PCR to pick up virus or fragments of virus in the sewerage system and could give an indication of whether or not that in that dormitory or that university has people who are carrying an infection. But remember, we're all building this ship at the same time. So answers to these questions are not yet available. What's important is that when new techniques are begun, they're evaluated completely. Right.
Yeah, that's a very good point. Okay, so we've had a couple questions about evolution of the virus. So Jorge asks if you think at some point the virus could mutate enough that vaccines currently in development may not be effective. And there's also a question about the potential evolution of mutations that make the virus more contagious with ongoing transmission.
Yeah, well, right now this virus is in almost all countries of the world. And in each of those countries, it's transmitting at a different rate, and therefore it's mutating at a different rate. So it may be that in one country, a mutation could in some way either cause an increase in transmission, decrease in transmissibility, or an increase or decrease in virulence. The question is, would that virus then be more fit and be able to spread into other countries, or would it just be in that country and slowly spread possibly to other countries? So we're past the time when a single mutation could modify the disease around the world, but certainly in each country, the virus is being watched for mutation to see in a correlation with clinical response and transmissibility, whether or not there are any changes. Whether or not the virus will mutate in such a way that it will require a new vaccine each year, the only experience we have in that type of a vaccine is, of course, the influenza virus. And as you know, there are 3 human influenza viruses endemic in humans, and those viruses genetically drift each year, so that there is a requirement for new virus sequence in next season's vaccine. Mm-hmm. For COVID-19, we don't even know yet if there will be an effective vaccine or how long it will be effective. Mm-hmm. And if it is effective, will it be modified by mutations? The virus is much more stable than the influenza virus. It's mutating at a slower rate. But of course, that's a question that will have to be addressed once we have a vaccine, if that vaccine is effective, and then of course we'll have all the answers we need.
Right. Yeah. It's a really valid point that these questions are out there, but until we get further into it, it's impossible to know.
But it's good to keep those questions in mind.
It is. Yeah, they're important. So we have a question from Jack, asking about what is your view on the influence of COVID-19 on healthcare systems overall in the long run?
Well, in Asian countries where there were SARS and MERS coronavirus outbreaks, South Korea, Hong Kong, Singapore, Taiwan, in those parts of the world, they learned a lesson and they built extra hospital bed capacity, isolation units, isolation beds, and many times those rooms have built-in renal dialysis equipment and ventilation. For example, in Singapore, there are 200 excess rooms just for an event such as this. So their hospitals have been able to cope quite well, and they've had a reasonably low case fatality rate among patients who were admitted to hospital. In Europe, the case fatality rate has been high, as it has been in the United States, and many of the reasons are because they hadn't learned the lessons that Asian countries had learned. They weren't on the alert early on, or they didn't at least start containing outbreaks early on. And as a result, they had a vast amount of community transmission, which overwhelmed hospitals, first in Italy, then in other countries in Europe, and then in North America. And those hospitals were not able to deal with infection as well as they should and had much higher case fatality rates. They just couldn't deal with all the patients who were coming in. They hadn't started to contain early enough. And at the same time, their intensive care units and their ventilators were many times overwhelmed.
Mm-hmm. Yeah, and in terms of a lot of the shifting to telehealth care that's happened, do you think that's something that is likely to at least partially stay for the long term?
I expect telehealth will remain. It depends on what you believe telehealth is. My understanding is that telehealth is when you call for clinical advice, and the person you call goes through a clinical algorithm and decides the next disposition, either to go to a physician or to take something at home. That's one way that telehealth can work. That's the way it's been working in the United Kingdom. It works that way in non-pandemic times as well. There's a number to call with your signs and symptoms. The algorithm is examined, and then a disposition is made. Whether that will become a part of medicine in other countries is not clear at present, but it certainly is a way of relieving both patients and medical practitioners from having to travel and go for something which might not need the attention of a medical trained personnel. So yes, I think telehealth will have a role. There's also been an attempt to develop devices that can contribute to contact tracing, and those devices are on a mobile phone with an app, and we're beginning to understand some of the benefits and difficulties with those, but all of these things should be evaluated because in the 21st century we can use these new tools, and we should use them in a way that they most maximize the effectiveness of our response to disease.
Mm-hmm. Yeah, technology is definitely another aspect of this. Yeah. So Irene asks for a question about her question is about the difference between the use of antigen versus PCR testing. How could they each sort of contribute to our contact tracing and surveillance?
Well, we don't know for sure yet, but there are lots of studies that are going on that are doing PCR and antigen detection, point of care antigen detection in the same people at the same time to compare. What we believe from studies that have been done by FIND, which is an NGO in Geneva, in Switzerland, that is validating tests, we believe that the antigen detection tests are a bit less sensitive than the PCR, which is the gold standard. But they may serve in certain areas where you're doing surveillance or you don't have the possibility of doing PCR. And in some places, using both might even be more able to pick up infections earlier or later on in infection. So algorithms are being studied for these tests now, but PCR is the gold standard. Antigen detection is being used by many countries that can't really afford PCRs because these tests are available, these lateral flow antigen detection tests are available at $3 to $5 US, which is much different than a PCR, and they do give you more rapid results. So to answer your question, if you're in a country where PCR results are taking 24 hours or more, you're better off doing an antigen test in order to determine those that you can and get them isolated right away.
Right, and then the combination would help to overcome that sensitivity if you have the capacity to then wait on the PCR for those cases that came out negative initially.
That's correct.
Okay.
That's correct.
Great. Okay. We have a question from Dwight, and I think this has been a big question in COVID-19, is understanding the reasons why there are differences in racial differences in susceptibility and disease severity and burden.
Yeah, thanks, Dwight. Well, it's the same answer that I had given earlier for why do men have more infection than women. And it's really not understood. And I have to say there are many cohort studies going on here in the United Kingdom, and I'm sure in the United States and in North America, to really understand what the issue is. Some of the hypotheses are that certain populations have not had access to the health promotional messages that others have, and therefore there may be populations with comorbidities that are increased. And so it's important to sort that out in the final analysis, looking for a genetic reason as well. And there are studies going on looking at genetic possibilities of why this is more serious in certain populations. But the answer is not yet known. What we do know is that everybody has to take care to protect themselves and prevent others, and especially those who have comorbidities.
Mm-hmm. And then also studies looking, and I think you mentioned this in terms of access, social determinants of health that may be affecting these differences.
That's right. We have to do a better job in equalizing health throughout our countries. That means making sure that people have access not only to clinical medicine when they need it, but to the public health and health promotion messages that are so important to help people live a healthier lifestyle. Because it's only through healthy lifestyles that we can prevent these comorbidities that are causing increases in mortality in those people who are infected.
Mm-hmm. Yeah, and access to preventive care and such. Okay, we have another question. This goes back to testing, but it's about serological testing. Sanjini wants to know, what's the significance or utility of serologic testing at this point in the pandemic?
Well, serological testing is very useful to see where infections have occurred. But a recent study published in the United Kingdom, again, has shown that antibodies detectable by the tests that we have today rapidly decrease after they've been developed. And so in a period of 3 or 4 months, many times it's no longer possible to detect antibody that was detected more close to the time of infection. And we know that in people who have had very mild illness, it's sometimes not possible to detect antibody at all, even right after the infection has occurred or after the PCR test becomes negative. And so these are questions as to whether or not we are able to detect antibody or will be able to moving forward, or whether it actually is decreasing. Because in countries around the world, about the maximum of the general population that appears to be infected is 15%. And in most countries, it's around 7% of the population that has been infected based on antibody determinations. But remember, there's also cellular immunity, and we're just beginning to understand what role that might play in protection, but it's very difficult to measure that immunity in surveys, so they wouldn't be used tests like that to determine where infection has occurred in a community. Rather, the antibody tests would still be used.
Okay, that makes sense. So I hate to ask this question, but it does come up, and I think, asking for your opinion on it, because it's really not an answerable question, but based on what you've seen so far, the few data that have come out, when do you realistically think or anticipate that a vaccine could be available for COVID?
Well, now I think Tony Fauci and the chief medical officer here in the United Kingdom and everyone who have had a preliminary look at some of the data are feeling that we might have an answer to whether or not there is an effective vaccine by the end of this year, around Christmas time, or even a little bit before. But then it requires rigorous licensing and a whole series of things. And so I think most people think that the first vaccines will go into an arm sometime in the new year, early in the new year. But it's also it's also true that some of these vaccines, those, for example, with an adenovirus backbone, will need to be kept at minus 60 degrees in the field while vaccination is going on. So there are all kinds of issues that will come up. First generation vaccines, as you know, are often not the one that's the one that we're looking for, but it's a step along the way to that final vaccine. Fortunately, the Ebola vaccine, which has been effective in preventing Ebola infections, also requires minus 60 degrees transport. And so there are portable containers at minus 60 that have been developed for use in the field in Africa. And that will certainly be useful in the cold chain in all countries forward. But these vaccines will certainly not be perfect. They will be vaccines, if they are effective at all, that will give a certain amount of immunity, but for how long, no one knows.
Right. Impossible to know that now. Sort of a follow-up question to that is, someone's asking you referred to vaccine being one tool, and so maybe if you could comment on your thoughts on the best way that a vaccine, if and when one is available and effective, what's the best way to use it from an epidemiologic standpoint in combination with other tools?
Of course, in my view, the best way to use it would be in the populations who are at risk of serious illness if they are infected, if those populations can be identified, and also in health workers. But there will be variations in countries depending on the amount of vaccine they have available, and many times it's a political determination rather than a public health determination. And I have to say, we've seen a lot of political determination in this current pandemic. In fact, it's been very difficult for the public health voice to have a place in many of the decisions made by heads of state.
Yeah, that's a very good point. It'll be difficult to know if it'll be able to be used in the best possible way.
Absolutely.
In this circumstance. Great. Okay, so I think we have time for one more question. Just trying to figure out to go here. Someone has a question. I guess this relates also to the discussion of antibodies. And Maritza just has a question about how often convalescent plasma is being used. That seems like a difficult question to answer, but how beneficial you think that might be. And
one of the treatments that's been effective against Ebola has been monoclonal antibodies. And I think the studies on monoclonal antibodies may in fact be available, the results available even before a vaccine. Mm-hmm. And so the question is, if they are effective, are countries ready to make them available? They might not be useful for people late in the progression of infection, but certainly given early in infection, as they're given for rabies and other infections, could have a modifying effect on the clinical outcome. And in some instances, they might even be able to use as a prophylactic in people who might be exposed. So lots of questions, but yes, we should never forget that there is work going on either monoclonals or on plasmapheresis antibody, and those are important as well.
Okay, great. Thank you very much, Professor Heymann, for that insightful presentation and answers to those questions. I'd also like to thank our listeners. As a reminder, to review the COVID-19 Comprehensive Resource Center on the Clinical Care Options website, click on the link in the show notes. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.